Good afternoon, everyone, and welcome to our panel, Demystifying FQHCs, Unlocking the Opportunity Within the Safety Net System. My name is Johanna Cazares, and I serve as Chief Growth Officer at Alcar Health. A couple of housekeeping items before we get started. Our session is scheduled for 50 minutes. We invite you to submit your questions through the app. And before we conclude, we will try to answer all the questions that come through. So, I hope everyone's having a great conference experience so far. I know I'm really excited to be here today. I am really happy to be moderating a discussion that is long overdue. And I'm happy that we're here today on the Medicarian stage. And why I am so happy and thrilled that we're here today is because we have some of the major players across the industry here. We have health plans, we have care delivery organizations, we have major FMOs, we have independent agents, and we have consultants and solution providers. My friends to the left of me are from the industry that holds up the system. They're from the sector of the nonprofit federally qualified healthcare system. We're going to use a couple of phrases interchangeably, so I just want to acknowledge that when our panel here references community health centers, we're also talking about federally qualified health centers, also known as FQHCs. So, as with most industry conferences, you see a lot of the same. You see familiar faces, you have a lot of the same discussions, you hear a lot of similar value propositions, and if you're lucky, you meet somebody new. You have a new conversation, or you hear about a new concept. Yesterday on the expo floor, I happened to see a little robot puppy. And that little robot puppy, out of all of the conversations I had yesterday and all the people I chatted with, that little puppy stuck in my head. I didn't have a conversation with the puppy, but that puppy stuck in my head. Why? Because it was new, it was novel, and because my brain registered something new. And so today, being able to bring you a new topic is the goal, to talk about how important and vital these individuals and the organizations they serve are vital to our healthcare system. So just by show of hands, I'd like to invite you all to just step out and by show of hands, how many of you have heard of federally qualified health centers before today? Yay. All right, well, if you don't mind keeping your hands up, how many of you, or you can put them down if this isn't you, but hold on. How many of you have had a substantive conversation with a healthcare leader about their organization, their patients, and how you can support? All right, so a couple of hands went down, and that's why it's really important that we're here today having this conversation. So I thank you for being here. So I'd like to ground us all with some stats because I know how important data is for everybody here in this room. FQHCs make up the largest primary care network in the country, across all 50 states. According to the National Association of Community Health Centers, or NAC, there are roughly 1,500 federally qualified health centers with 17,000 locations across the nation, all 50 states. They have a workforce of over 330,000 individuals. 52 million patients are served annually. That's 1 out of every 7 Americans. The fastest growing segment, and this is where everybody's gonna start drooling, I'm sure, the fastest growing segment amongst that patient population that is currently being served is over the age of 65. And of those Medicare eligible patients, half of them are dually eligible. Another fact that should ground everybody in why this is a new topic and should be we should have more people sitting in this room, but I believe the right people are here today. The National Association of Community Health Centers also shares a data point regarding the operating margin for these community health centers. They operate with a margin of less than 2.4%. So if we can learn anything today, I hope my goal is for one, to create the awareness, to create understanding, and to really understand how a nonprofit health system is able to take care of this many people on that, how they do more with less, or less. Thank you. All right, well, today I am joined by 3 leaders who are boldly supporting and stepping into this opportunity, have tons of insight and experience, and lots to offer. So I'm going to ask for each of you to please share your name, organization, role, and again, just to kind of ground us into the connection to your work, what's one sentence that you can share that keeps you connected? So I'll start with Missy to my left.
Hi, good afternoon. Teresa Nitescu, Missy is my nickname, and I'm the Chief Operations Officer for Northeast Valley Health Corporation, which is a large FQHC in Los Angeles, northern Los Angeles County. And what keeps me grounded, I've been with Northeast Valley 39 years, so I stay because I love the people. I love the staff. I love the providers, and most importantly, I love those patients.
Thank you so much, Missy. Briana?
Good afternoon, everyone. I am Briana Cardoza. I'm the Chief Business Development Officer for TrueCare, which is a FQHC serving San Diego and Riverside counties. We serve about 70,000 patients each year through 23 different locations and growing. I have had the pleasure of being with TrueCare for 16 years now, maybe 15, I don't remember. And what keeps me grounded, very similar to you, Missy, I'm absolutely grounded by our team members and our shared connection and our shared commitment to our patients and our community. You walk through the doors and you can feel the connection and the commitment that everyone has to our community. So that certainly keeps me grounded.
Thank you, Briana. And Jaime?
Good afternoon, everyone. My name is Jaime Rosales. I am the founder and CEO of JAR Insurance Services. We are an NMO based out of Southern California, Los Angeles County. We've been in business for 17 plus years. And what keeps me grounded is 2 things. One, knowing that we make a difference with the individuals that we serve. We serve a very vulnerable population that needs a lot of help. That keeps me grounded, 1. And 2, the agents that we work with. The agents that we work with have what I like to call a serving heart. They understand that the people that they serve could be their parents or grandparents. And that's really important. And those are the type of individuals that remind me every day that what we do matters.
Thank you, Jaime. So to bring us back to something that I'm sure you guys are now hearing the opportunity, you're understanding a little bit more, just to again level set on the synonymous nature of the community health centers and FQHCs. So when our panelists mention health center, that is because the FQHC label is a designation more so about the financial aspect and how they get paid. So just wanted to call that out. So let's jump into some questions here. I will ground the audience again, just back to the opportunity regarding the population that's being served today and who that population is that all of the agents and the health plans and other stakeholders are mostly interested in when it comes to the target audience of who we all serve, and that is the older population. So when it comes to a patient within the health centers, it is no different for them when they turn 65. There's still a lot at stake, there's still a lot of confusion, and there's still a lot of trust that the providers here to my left are leveraging when it comes to keeping that patient connected. And so, Missy, I do want to have you answer this first question here. So Northeast Valley Health Corporation serves approximately 83,000 patients, yet 85,000 patients, I stand corrected, 85,000 patients. Yet historically, FQHCs have focused on their younger populations. What was the turning point that made Medicare growth a strategic priority of Northeast Valley, and how did your organization gain buy-in?
Well, Johanna, I think that the one thing that FQHCs are facing all over the nation, it's the most pressing issue right now, is a financial issue with the enactment of H.R. 1, which is also known as the One Big Beautiful Bill. Our health centers face some serious challenges going forward with the Medicaid program, which is our largest revenue stream, and that's both at the federal and the state level. So that could mean the loss of patients, losing patients, and also patients losing insurance and having to go on our sliding fee program. So Medicare was actually not, has not traditionally been a big payer for us, but we have to sort of rethink our strategy in terms of payer mix. I think another thing, of course, is that, as you mentioned, FQHCs have traditionally served a younger population, children and families, and I think it was based on how Medicaid paid across the country. But let's face it, we have an aging population, slowing birth rates, increasing longevity, and coupled with younger families basically moving out of, in our area in LA, it is too expensive for young families to live. And so that is another factor that we're rethinking how we approach our patient population, our payer mix. And lastly, and I think this is the thing that's the most important, we've been treating these patients sometimes for years. We have patients that started with us as newborns, and we're seeing them in their 40s and 50s. Why not have them stay with us through their old age? Health-wise, we know them best.
Amen to that. One thing that I was thinking about just as prepping for this conversation was TLC, the trust, the longevity, and the care that our health center partners have already established with those patients. And so really being able to, again, create that awareness and invite others to learn more and to really develop more awareness, understanding, and I would just say partnerships with the right intention. It cannot be a transactional partnership. It is really truly about understanding how to best serve. And so I'll go ahead and send my next question over to you, Briana, regarding TrueCare's strategic priorities that led you and your organization to really invest in Medicare growth. How does that align to your broader mission as an FQHC?
Well, our mission as an FQHC is to improve the health status of our diverse community. And so every year, day in, day out, we're consistently assessing who our community is and what their needs are. And Missy already mentioned it, our patients are getting older. They're aging into Medicare, and that is our community. And so it's our calling, it's our job, it's our responsibility to tailor to that population, because that's our community and that's our mission. That's who we are, that's what we do. And so from a strategic perspective, we're always grounded by quality of care, the patient experience, and growth in general. That comes in different forms: size, locations, how we deliver care, et cetera. And when we look at those pillars, we realize that if we're going to serve our evolving community, which are those that are aging in, we need to look at all of those things and do things differently. And that became kind of our central ground several years ago, and why we prioritize the need to create a Medicare strategy. Granted, our Medicare strategy 5 years ago looks very different than it does today. And it'll look different a few years from now. But the reality is we recognize the need to have a specific strategy for that population specifically because it is our community. And just really quick to play off of what Missy said, these are patients that grew up in the community health center system. They know no different. If they were children and now they're turning 64, 65, and they're getting Medicare, there is this common fear that they have to leave, that they have to go elsewhere. Suddenly, the system gets very complex, it gets very confusing, and they don't want to leave. They're well established, they have their provider, they know where to go, they know how to access services, and they don't want to leave. And it's our responsibility to ensure that they don't have to. And as a community health center, we want to ensure that we're well equipped to provide appropriate care for them.
Thank you, Briana. And I think this is the perfect time to bring Jaime into the conversation, because if it weren't for the partnership with JAR Insurance Services, who works in support of both Medicare strategies for Northeast Valley as well as TrueCare, there really would be that leakage and that loss of patients' connection and trust. And so, Jaime, my next question is to you. When it comes to the work that the agency does with FQHCs up and down California, can you share a little bit more about what a mission-aligned broker partner looks like?
Sure. Thank you, Johanna. You know, for us, I think being a mission-driven agent or agency means that you shift from a transactional perspective to building a relationship, because these are individuals that you have to understand that require significantly more assistance than any other client. So if you're serving a traditional MA member that is solid middle, maybe upper middle class, they're more on a transactional basis. You can sit with them, they're willing to look at facts, they identify the plan that works for them, and they're making a choice. With the beneficiaries that we're serving here with the community healthcare centers, they require much hand-holding. And for us, that's really important. So when you enroll a client with one of their contracted health plans, that's the beginning of your relationship. And I'll give you an example of what being mission-driven means. I was having this conversation earlier before we got started. A lot of these patients, they have language barriers, educational barriers. Some of the people that we serve, you know, they have maybe a second or a third grade education, and they receive mail that has nothing to do with healthcare, nothing. And I'm sure it happens in your centers all the time. They walk in with a stack and they say, "Can you please read this for me? Can you please help us?" We do that. We do it because that means that we're there to serve them. You have to be mission driven. And I say this because unfortunately there are some agents that still have a transactional mindset, meaning that they enroll them with plan A, B, or C, and if there's a problem, they coach them and instruct them, call 1-800-HEALTH PLAN. That's not a JAR agent. If you want your agents to stay, or your beneficiaries to stay with the FQs. So being mission-driven is the heart of what we do at JAR. Thank you.
Thank you, Jaime. I'd like to pose this next question to both Missy and Briana regarding the Medicaid policy changes that you mentioned from HR 1. Having them push FQHCs to look at Medicare as a growing revenue source, knowing that you also have that operational budget of negative 2.4%. Can you just share a little bit more about how that external landscape has shaped the internal decision-making for both TrueCare and Northeast Valley Healthcare Corporation? Missy, we can go start with you.
Sure. Well, in terms of our infrastructure development, one of the things I wanted to share is, you know, early on we realized that we had to re-strategize about our retaining more of our Medicare patients, and a few of the leaders, including myself, the chief medical officer, and a few physicians, decided to participate in a statewide collaborative for retaining older adults, because historically that has not been the population that clinics have served. And when we did this across the organization assessment, we learned there were some aha moments. One is that obviously your facilities need to be able to be ready for an older adult population, including being ADA accessible, and not all ours were. The biggest thing was our appointment slots. So because federally qualified health centers get paid by the visit, the more visits you see, the more money you make. But with older adults, they need 2 or 3 appointment slots because they have complex needs. And so I think historically that's been one of the reasons why FQHCs have not focused on the older adult population. Many of the clinics across the nation are moving into alternative payment models, and those alternative payment models will set up a payment structure that's more a capitated per member per month type of fee rather than a per visit. And that really is going to afford clinics the opportunity to serve who they need to serve in the time frame they need to serve. The other thing is that we did, as part of our collaboration with JAR, we realized that we still needed an internal champion to sort of help the older adults navigate getting to JAR and also answering other questions. So we set up something like a concierge service for older adults. We have an older adult specialist that basically answers questions, and just like Jaime mentioned, she's bilingual, bicultural. She can navigate people in the community to other resources, not just signing up for Medicare, but just other resources in general. The other thing that we did that in the last year or so, and I'll be honest with you, I'm one of those older adults, so I saw some of these challenges within my own healthcare system and my husband's, was there's lots of technology that a lot of healthcare providers use these days, but it is pretty hard for older adults to navigate some of this technology. So I added a live operator feature so that when a patient needed to talk to somebody at one of our health centers, and we operate 18 health centers, that zero feature goes to a live operator, and that's been a game changer. I have to tell you, older adults actually call me and say thank you for that one. And then, of course, many of you, as well as myself, we have patient portals. The older adults really struggle with this, so we also added a live operator to help older adults navigate through their patient portal to be able to get results, referral authorizations, et cetera. Lots of stuff goes into those portals. The one thing that surprised me in the participation of this collaborative, and I don't know how many of you know this, that we had been on the path of possibly wanting to hire a geriatrician, and only 1% of all the physicians in this country are geriatricians. There's only 7,300 in the entire nation. Now that's a scary thought considering how many baby boomers are aging up.
Thank you, Missy. And I want to go ahead and acknowledge that the work that you're doing to not just lead with tech, but still keep that human connections. That's really strong. Briana, for you as the Chief Business Development Officer, I know you oversee the growth and a lot of other aspects that go along with it. One thing that Missy mentioned was the contracts and ensuring that they are advantageous to FQHCs. There's a question here regarding what other services do FQHCs offer? Is it mainly primary care, or do they offer dental behavioral health? As the Chief Business Development Officer, if you'd like to go ahead and take that and then add a little bit more color to how the contracts are developed so that all of the services for FQs live within that contract.
Sure. So the question around services, all FQHCs are different. However, I can share most do offer more than primary care. At TrueCare, we offer primary care, dental, behavioral health, chiropractic, podiatry, cardiology. I'm going slow because I know I'm going to forget something. And other enabling services. We offer enrollment assistance services, case management, health education, transportation, outreach. I'm probably forgetting a lot, but the point is we offer comprehensive services, and our goal is also to offer as many wraparound services as well. And in the past few years, we've really taken, it made it a priority to also address social determinants of health. We have food distributions, there are, we work with other partners for housing, et cetera. So our goal is to ensure that we have as many services as possible to provide that comprehensive care. And in terms of contracts, we want to ensure all of our patients have access to all of those services and want to ensure that when we're negotiating a contract that we're able to offer all of those services to any of our beneficiaries. And I will shift a little bit and talk about the Medi-Medi population really quick. Most of our patients are dually eligible, and it's beneficial both for us and for the patient to ensure that if they're dually eligible, that they are enrolled in both. And our strategy several years ago was primarily on the Medicaid, transitioning into Medicare eligible. But now, fast forward, we're actually seeing a lot of Medicare patients that are likely eligible for Medicaid as well. And so we want to ensure that we provide as much assistance as possible to ensure the comprehensive services and that our patients are able to access all of the services that we have to offer. I hope that's along the lines of what you were looking for.
Yeah, thank you. And then turning over to Jaime, as far as the offerings and just ensuring that the agents are really focused on the needs of the patients versus just what services the FQ has, how can you ensure that the agents are doing that thorough needs assessment to keep them connected to the FQs and the contracted health plans?
Sure. So one of the things that's great about working with the FQs is that a lot of the services are already in-house, right? So the agents work relationships at the local level with the staff, ensuring that they understand exactly who does what and how they can help them navigate that. In addition to that, I think one of the most important things that the agents have working with the FQs is that they develop such a great relationship. So as an example, we have one FQ here has 23 clinics, right? And then 18 centers. So these are a lot of facilities. So it's a lot for an agent to navigate, but working with a team of agents, we're able to manage and ensure that we're educating the beneficiaries accurately. But it's all about having a partnership and a relationship. They're identifying people that have Medi-Cal, maybe they're aging into Medicare, or maybe they only have Medicare, and having a conversation with them, you identify that maybe they qualify for additional services such as LIS, Quimby, Slimby, or they could qualify for full Medi-Cal in California or Medicaid, depending on the state that they're in. And that's working collaboratively. That's the key.
Can I just elaborate on that a little bit, our JAR agents are members of our team. And from the patient perspective, it's very seamless. They almost think that the JAR agent is a TrueCare employee, which they're clearly not. They are embedded, I'll give it an example. One of the agents is embedded with our resource center where a patient or community member, doesn't have to be a patient, anyone from the community can walk in and get assistance with CalFresh, food stamps, Medicaid, other assistance as well. And the agent is situated right there. That doesn't mean that's the only way that the agent gets referrals, but my point is that they're well embedded with the rest of our team, so they're knowledgeable about our services, our culture, who we are, and from the patient perspective, they see them as one of us, and we do as well.
Thank you, Briana. I want to go ahead and just answer one question that came in here. It says, sorry, what is FQSC? It's FQHC, Federally Qualified Health Center. So hopefully that clears it up. I do want to say that in the past, I've heard health plans actually refer to an FQHC as an HQ. And so again, that kind of gives you more insights into why we're having this conversation today, just to really clear that up. Another question here, you mentioned because of budget cuts, people will qualify or pay on a sliding scale. What does that mean?
I can answer that. So one of the hallmarks of community health centers, federally qualified health centers that are funded through the government, is that for patients under 200% of the federal poverty level, if they are uninsured and have no other resources, the federally qualified health center has to offer a sliding fee scale for all the required services that they provide to the community. And that could be as low as $20. So while that's totally beneficial for patients that lose their insurance, from a community health center standpoint, that could mean that from a revenue perspective, that what we might have been getting, let's say $250 a visit, we'll only have get $20 under that sliding fee scale. So that's why these changes to Medicaid are so alarming for community health centers, especially when Johanna shared our operating margin is so slim.
Thank you, Missy. Next question that we have here that came in from the audience. How are FQHCs addressing patient retention for the dual population, given complexity of navigating both Medicare and Medi-Cal benefits versus fee-for-service? I think the first step, again, is, and I'll turn it over to the panel to chime in, but I would say that the first step is acknowledging that there is a population within their four walls that is already has trust, already has established care, and really leveraging partnerships such as JAR Insurance Services to go ahead and assist. But I'll go ahead and allow for Missy, Briana, and Jaime to chime in a little bit more with maybe some anecdotal insights about how you all are focusing more so from your specific health centers and experience.
I think the question was around retention, and I mentioned before, we feel a sense of responsibility to be proactive with our patients and the community. The reality is Medicare, Medicaid, it's complex, and to assume our patients or community knows what to do is just naive. And so with that comes increased enrollment efforts, increased outreach efforts, which is also a collaborative strategy, and being proactive in educating our patients and our community about what's needed and driving them through the process. Because if we wait for them to come to us, the likelihood is it's too late. Fortunately, that's why we are an FQHC. We are a safety net because we see patients that are on insurance, they're covered, and then they're not. And we still see them when they're not. Then they're covered again, and then we still see them, and then they fall off of coverage. We still see them. We are the safety net and ensure that we're there regardless. But our biggest strategy is ensuring proactive outreach and education, assuming the patients know nothing and really walking them through the process so they know what they need to do, when they need to do it, and how to do it.
Thank you, Briana. Missy, would you like to add to that?
We work closely with our IPA. We belong to what's called Healthcare LA IPA, which is one of the largest IPAs in California and certainly the largest in Los Angeles. And it's made up of many, many of the safety net FQHC providers. But they basically introduced us to JAR early on, noticing that our Medicare population was starting to grow. That being said, we still have a lot of Medicare fee-for-service, and part of the dialogue with patients, and one where we, when we send them to JAR, we hope that they'll convert to Advantage plans, because that's certainly, number one, it gives them a lot more benefits, and many of these patients need those benefits. And two, it is more advantageous for the FQHC through our IPA contracting model.
Thank you. Jaime, any pointers from your end regarding the retention aspect of?
Yeah, I think that's a very valid point, and I want to kind of say something because there's a line here I want to answer it. It says, it seems that JAR is already working closely with centers. Is there room for more agents? Let me just say, there are hundreds, if not thousands, of FQHCs across the country. We don't have enough agents, otherwise there would be a JAR agent everywhere. But there's plenty of opportunity for everyone here in this room if you want to work with FQs across this country. The thing, though, I want to go back to is, remember, this is not a transactional relationship. If you want to work with FQs, you have to be prepared to invest a lot of time building the relationship with the leadership, with the front office staff, and with the community that serves this population. If you're unwilling to do that, then you're going to struggle. And to answer the question as to the individuals that are becoming Medicare eligible, and some of them are leaving FQs, that was an opportunity that we saw many years ago. So JAR has been working with FQs for 17 years. And the reason why we started working with them is that we saw the trend. A lot of their patients, as they were becoming Medicare eligible, they were leaving and joining a competing IPA or quote physician, because they believe, well, now that I have the red, white, and blue card, I can go and see Dr. Jones down the street. They assumed they had to leave, and many of the FQs lacked at that time programs to educate. And working with our partners here, we've launched educational seminars. So we're doing Medicare 101s on a regular basis. We're doing informative presentations. We're out in the community educating. It's not a one-time, it's a continuous process. And that has led to not just enrollments for JAR, which we're happy, but it has also led to higher retention for our partners. And they can see it when they look at their eligibility charts. So we're very proud that we've been able to do that in collaboration. And you've heard me say that word multiple times, and same from our partners here. It's all about collaboration. It really takes a village to serve this population.
And trust. Just want to underscore, as an FQHC leader, we have to trust our agency. We did, TrueCare did work with an agency prior to JAR, and I'm going to say it, I'm going to be bold and say that I'm glad we transitioned. The trust is so critical. We are giving our patients to another agency that is not TrueCare. We don't have control over how they serve the patients. We don't have control over what they're saying. We don't have control over the scripting. But we are giving our patients and speaking on behalf of the agency that they're going to have a good experience, and sending them over and hoping for the best and hoping they come back. And so that level of trust is so critical. So I can't underscore that enough. And the credibility, and obviously you go out on a limb and you hope that you see the data come through months, years later, but you have to have that level of trust to be able to look your patients in the eyes and say, nope, you're in good hands.
Thank you so much, Briana. Missy, anything to add there?
I just wanted to say that, with our relationship with JAR, I was looking at the data last night. And actually, in 2025, all the patients that we referred to JAR for enrollment, we had an 80 to 90% retention rate. So excellent job.
Thank you.
Thank you. I think Jaime said it best. It does take a village, and it's not done alone. I will say that there is also a clear difference in how you work with a FQHC versus how you work with just an independent neighborhood provider. And that's something to really call into focus, because one of the questions here was, who do I speak to, to get to work with an FQHC? And it's typically not going to be your traditional front office staff. Yes, they are there, but you do really need work from the top down, because you need to understand the organizational design, the just the operating constraints. You really need to understand it before you can step in and truly have a good, deep relationship. Just like when you're dating, you need to really get to know that person in order to establish a deep connection. And that's really I would say this is a testament of the work that has been put in year over year. It's not perfect, but there is an opportunity for everybody in this room to really, again, grow your capacity for understanding what an FQHC is, who they serve, how you can serve. And that's really why we're here today. So I'll take a couple of other questions here. Jaime, I'm going to go ahead and give this one to you. Are D-SNP that manage both Medicare and Medi-Cal a better option than a C-SNP plan? And I think that's all subjective, but...
Between a D-SNP and a C-SNP, I'm sure everyone here in this room is an agent or you're familiar with the term. So C-SNP is someone that has a chronic illness, right? A D-SNP is someone that has Medicare and Medicaid. That's why we are agents, right? We're doing needs analysis. If you're working with a client and in your analysis you identify that they have a special need and maybe there's a C-SNP plan that your partners also accept, then consider that one. But again, you do that in collaboration with the team that you're working with. But there's no such thing as one is better than the other. We're all individuals. We all have different needs. And you have to ensure that you're doing the needs analysis and that you're always placing the interests of your client first. That's paramount. That's our North Star. And your partners. If you're doing that, it leads to retention, which is what they want, right? And it's what we want. Because if we retain our members, we're building our book and we're building residuals. So that's very important.
All right, thank you, Jaime. Another question here, there's a lot coming in now. So one is, how can FQHCs effectively identify patients to connect with an agent or agency and recommend whom they should speak to and keep trust with clients? So trust being the key word. And that brings me to my next question regarding the data. So Briana, walk us through the data that informed your Medicare strategy. We'll tie it back to this question. What did your data reveal about your aging patient population, and how did that shape your approach?
Well, that's relatively easy. We're consistently looking at data, and data shows that we have a very active pipeline. Year over year, there is a good number of our patients that are going to turn 65. We have a very, very active pipeline. You go back 10 years, and we know that there's a good chunk of patients aging in to Medicare year over year. So we know that there's that active pipeline there. And then when we dove deeper into the data, we're looking at where are they at currently? Are they on Medicaid? Are they on Medicare? If they're over 65, we look at even more critically to see what they're eligible for, what they're on, and then proactively do some outreach to ensure that they are enrolled in what we think they should be enrolled in. And And then how do we get patients from here to the agent and to enrolled? That comes a variety of different ways. Yes, we're doing proactive outreach via phone, via mail, via texting, but a lot of our, I guess you could say, referrals and getting scheduled onto an agent schedule comes from our providers and comes from the exam room and talking with patients at the front desk. But the reality is patients listen to their providers. Even though we're trying to preserve them and only use them for what they need to be used for, they listen to their providers. And we have internal champions that are well aware of our agents, well aware of the experience. That's where the trust and credibility comes in. So we have clinicians and providers that are actively putting patients onto the agent's schedule.
Missy, anything you'd like to add?
I was just going to say, I agree with everything that Briana said. One of the things that we did as part of that participation in that older adult collaborative was, we have patient lists we run all the time, just like Briana. But what we did was we developed a birthday card for the aging up older adults. And I think we mail it out at 64 and a half or something like that. And it is both, a greeting and also a plug to meet with our JAR representative. And what's nice about that is, again, it shows that collaboration between our agency and JAR, and that, it's a trusted partner.
Thank you, Missy. Jaime?
It all comes to trust. And I think that was an important word that we heard here on the stage today. It's about trust. We have built a relationship of trust with our partners. And we are also an organization that meets what the beneficiaries need. We meet with them where they want to meet. And I can tell you that is so important, building trust with this population. And we can work with them and information can be shared, but we have systems in place so that we can do it compliantly, following the spirit of the CMS guidance. We're protecting anything that we have in terms of information through our compliance department. So we work very compliantly, and I want to just emphasize that Briana shared that they had another agency that they worked with before JAR. And unfortunately, because there's a question up here that I want to read here, it says, can you share how to connect with FQHCs? I work with one, but it's limited. Others say they can't partner with one broker or already have navigators. I can assure you, whoever you're speaking to, they probably had a bad experience with another agent or agency. And unfortunately, the bad actors create additional barriers for the good agents. And here's the good news. The majority of the agents want to do what's right. The majority of the agents are there to serve their beneficiaries. But those bad actors create obstacles for us. So focus on trust. Ensure that whatever you commit to, that you deliver for your beneficiary and for your partners. If you break the trust, you're not only hurting the beneficiary, you're not only hurting your partners, but you're also closing the door for other agents to serve other beneficiaries that really need your help. They need your help. This population does. So it really is a privilege to be able to serve them compliantly.
Thank you, Jaime. I want to just bring it back to transparency. I know we've mentioned trust a ton. One thing that I've heard over and over again is numbers don't lie. And so when you share data, quantitative data, back to your partners, the FQHC, about how many patients you assisted, what plans did you enroll them to, and that really does enhance and build that trust. I would say as a partner, really ensuring that there's a good feedback loop, that you're able to not only share your quantitative information, but you're able to share insights. So all of the brokers here have such a good connection to the communities that you're already serving and a good understanding of what consumers and the patients are looking for, how they're experiencing their care at the FQHC. All of that information is pretty vital. And so that in and of itself, I think makes for a good relationship as well. And that's really what we do month over month over month. We are combing through data. It is not easy. It is not pretty, but we are combing through the data to make sure that we are being good stewards and good partners and providing that information back. And we really couldn't do it without pulling our hair out or or just trusting each other. And that's really what it is about. So in closing, I hope that everybody is walking away with a better understanding today of federally qualified health centers. Again, they are called community health centers more widely. And I want to just thank our panelists today. So I'd like for you to just give everybody an applause and thank you all.